Myocardial infarction, irreversible necrosis of cardiac muscle due to prolonged severe ischemia due to rupture of atherosclerotic plaque which occlude the coronary artery due to vasospasm emboli vasculitis. So let's look at in detail about myocardial infarction. It's further divided into ST segment elevation MI, non-ST segment elevation MI, STEMI, NSTEMI. NSTEMI is unstable angina. There is increase of marker of myocardial infarction such as troponin, CKMB. No ST elevation is seen. The infarction is limited to subendothelial, that is, inner one third to half of the wall is infarcted. Then we have STEMI, STEMI, myocardial injury. There is increased myocardial myocardial infarction markers with ST segment elevation. There is transmural infarct, that is, the entire thickness of wall undergoes necrosis. Etiology of myocardial infarction: atherosclerosis, embolism, thrombosis, vasospasm. The other conditions which increases oxygen requirement such as heavy exertion, fever, hyperthyroidism. The conditions which decrease oxygen delivery such as hemorrhage, anemia. Risk factors for myocardial infarction. It includes modifiable risk factor, non-modifiable risk factor. Non-modifiable, which cannot be modified, such as age, gender, family history. Modifiable risk factor like stress, diabetes, hypertension, tobacco smoking, alcohol, obesity, hypercholesterolemia. Pathogenesis of myocardial infarction. It begins with coronary artery which has atherosclerotic plaque. There is sudden rupture of plaque. The thrombogenic plaque exposed to platelets. Platelets adhere to the site, initiate sudden thrombus formation. It's one of the main steps. Sudden thrombus formation. Platelet activation takes place, forms aggregation, formation of microthrombi on the plaque. Activated platelet release mediators. Mediators cause vasospasm at the site of atheroma. Tissue factors released at the site of acute plaque change. Activates coagulation system, increases size of thrombus. Within minutes, thrombus occludes the lumen. So if this is the lumen, the thrombus occludes the lumen within minutes. Then ischemia, hypoxia, angina. These are the sequence in which you need to remember. Then thrombolysis occurs in unstable angina. Permanent thrombus occurs. If permanent thrombus occurs, there will be necrosis of muscles. It causes myocardial infarction. Clinical features. The symptoms include chest pain, dyspnea, excessive sweating, lightheadedness, palpitation, dizziness, fatigue. Main symptom, the chest pain. The nature of the chest pain should be described. It's substernal, constrictive, tightening or squeezing type, and it radiates to left shoulder, left arm, neck. So if this is the body, left shoulder, neck, and left arm, this is the nature of radiation. Severe than severe if it angina lasts more than 20 minutes. The signs includes sweating, bradycardia, tachycardia, third and fourth heart sound, narrow pulse pressure, crepitations, JVP increased, pericardial friction rub. Laboratory markers of myocardial infarction. It includes troponin, CKMB, LDH, myoglobin, troponin. It's the most specific, most sensitive. Onset 2 hours, peak by 4 to 48 hours. Normalization 7 to 10 days. CKMB, it's sensitive but not specific. 2 hours onset, 2 to 4 hours. Peaks in 24 hours. Normalization in 3 days. LDH, 24 to 48 hours. There is onset. Peak many days. Normalization 7 to 14 days. It's non specific. Myoglobin, it's the earliest marker. Onset 1 to 3 hours. Since it's earliest marker, it has to have early onset. Peak 8 hours. Normalization 2 to 3 days. Investigations. ECG, in a normal ECG, as you can see, there will be P wave, QRS complex, T wave. In ST elevation, STEMI, we can see that ST has elevated from the normal line. More than 2 mm of elevation is seen. There will be T wave inversion. Blood test C reactive protein ESR. Next, we have management of myocardial infarction, complications of myocardial infarction. Under management of MI, in first 24 to 48 hours, admit the patient to the hospital. These are the key drugs which you need to remember: morphine, oxygen, nitroglycerin, aspirin, clopidogrel, thrombolytics such as streptokinase, anticoagulants, IV heparin, beta blocker, calcium channel blocker, nifedipine, hydrostatin, atorvastatin. Within 12 hours, reperfusion therapy can be initiated. So, when you look into reperfusion therapy, it includes percutaneous coronary intervention, angioplasty. The indications are ischemia symptoms less than 12 hours, cardiogenic shock, acute severe heart failure. Then we have fibrinolytic therapy initiated within 30 minutes, plasminogen activator such as streptokinase, TPA, altiplase, which lyse the clot, recanalize the vessel. Contraindication: cerebrovascular hemorrhage, hemorrhagic stroke, recent surgery, uncontrolled hypertension, bleeding. Then we have something called CABG, which is coronary artery bypass grafting in patient with left main stem disease and impaired LV function. And finally, the complications of MI. Let's remember this by mnemonic: Darth Vader, death, which is sudden, arrhythmia, rupture of ventricle wall, IV septum, papillary muscles, tamponade, cardiac tamponade, heart failure, which causes pulmonary edema, valvular disease such as VHD plus MR, mitral regurgitation, ventricular aneurysm, Dressler syndrome, embolism, mitral regurgitation. And finally, to summarize, we have definition of myocardial infarction, types: NST-EMI, STEMI, etiology, risk factors, pathology, pathogenesis, clinical features, signs, symptoms, laboratory markers. Laboratory markers are very important. Make sure you had this entire 4 laboratory markers with times of onset, peak, normalization. Then we have investigation and blood test, and we also have the management, uh, the basic drugs which you need to remember. Then reperfusion therapy, PCI, angioplasty, fibrinolytic therapy, CABG. Then finally complications of MI.